Okay, so what happens when the proximal, how is the proximal contact placement on the anterior teeth affect the way the teeth look? So we I have a model over here, so that's a little bit easier to explain. So the buccal side of the tooth, it appears wider versus if you look at the lingual, okay, it like looks narrower, right? And then on the incisal, the tooth looks wider versus on the gingival where it's narrower. And the shape results in the fact that the contact is near the incisal third of the tooth, and in the maxillary central it's the most incisal versus it starts going a little bit gingival as you go posteriorly. Okay, so this, I think we've discussed this point before, but like say if you start adjusting your proximal contacts and you use a coarse disc or stone, you'll have to adjust a little bit more to get it back to its initial and to get it back to its initial like smoothness. So you might end up polishing more, which can result in bigger problems, because if the contact is loose, then we cannot cement the crown. Okay. Restoration seating. So this is how we confirm that our restoration is seating properly. First thing that you'll confirm is that once the proximal contacts are adjusted, you'll see that the marginal ridge heights are even. So it'll be close to the adjacent tooth. You can get a sense of that. And then like here, the restoration is completely supragingival. So it's very easy to see that there is no gap in the margin. Okay. So margin fit evaluation, how much of a gap in the between the crown and the tooth is considered to be within acceptable limits? So it's ideally less than 50 microns, and then like in clinical, it should be less than 100 microns and not more than that. So how are we going to gauge how much is 100 microns? If you see your hair, it's between 40 to 100. So it's basically, you should not be able to, it's thinner than a hair, right? That's the amount of gap. So within the human eye, you should be able to not see any gap. If you can, then it's going to be too much. And the diameter of an explorer tip, this is a new explorer tip which has not have that wear and tear, not the thick explorer tips that we have at some offices, is 10 to 50 microns. So that also gives you an indicator of whether like if an explorer can go through the interface between the crown and the tooth, then it's not seated all the way. And the size of Streptococcus mutans is 0.5 to 0.75. Of course, it's a microorganism, so there's still a chance that that's the reason why we want to make sure it's as the gap is as small as possible, because we don't want bacteria to be able to enter between our crown and tooth interface. And of course, with the 10 to 50 microns, once we add the cement, then there's going to be a little bit, even that closes the gap a little bit more, but while seeding, it should not be more than 100 microns. Okay, so what are the things that will happen if there is poor marginal fit? So, there'll be contact of cold, hot liquids because the crown prep tooth is anyway going to be sensitive. So if there's a gap between the crown and the tooth, then it'll cause sensitivity. The cement can get washed out. The mouth is used for a variety of reasons throughout the day, drinking water, drinking acidic things, hot things, coffee, tea. So that'll cause the cement to wash out over time and the crown can get dislodged. Then plaque and food accumulation can occur because of the gap that is present. And it's one of those really inconvenient thing where the patient needs to keep using a floss to take it out, and it makes it really uncomfortable over a long period of time. Caries, of course, there's chance of recurrent decay if there's a gap for the microorganisms to go inside, and it's actually a lot more worse than the normal tooth, right? Because now the food will go there, it's going to stay there, the microorganisms are going to go there, it's going to stay there, there's no way for it to be cleaned out. So the chance of recurrent decay, gingival inflammation, periodontal disease all increases a lot. And the unfortunate part is that every time we take an x-ray in the crown, we can't really see what's going on underneath the crown. So pretty much by the time we find out that there's something going on, it's quite late. So this is really important to have a good marginal fit. Okay, so what are the ways that we can evaluate the margin, right? So one way is to, of course, do it with your eyes, tactile sensation, but the other way that it's very clear is also taking a radiograph. A bite wing is usually a more accurate way to figure out the way the margins are. But if you can see in these x-rays, it's very easy to see that there's a gap here. So this is not an acceptable, if I see this, I have to redo the crown, not cement it like this. And here you can see that the opposite, right? What will happen if there's a hypercontour or there's an overhanging margin? So this is going to actually start causing periodontal problems. And if there's a slight gap, of course, then the bacteria can go in too, but this is really not good for the gums. And I can see this area being a part where the fluid accumulation and the bacterial entry can occur. Of course, if there is a hypocontour, then there'll be a ledge, and again, that'll be an entry path for the bacteria. Open margin assessment. So the proximal contact is still too tight. And that could be I think that's one of the major reasons why the crown is not seating. So we have to go back and complete the entire proximal contact procedure. How do we check it all over again? Make sure that it's not too tight. The other thing that could happen is that there is an internal binding. So when you are placing the crown, there is an interference. So we have to figure out the interference. I'll talk about how that is done. And of course, if the impression had gotten distorted where, the patient moved and, the tray wasn't held till the entire impression was set, then that puts us back to retaking the impression and, all the way back to that step. So if there is internal blasting, there are a couple of ways that you can determine that. First, you have to sandblast the surface of the metal so that it's easy to figure out where there is the binding is happening. Sometimes if you just turn the crown, sometimes you see a small speck, and it's really an overlooking of the lab, because they have to make sure that that's not the case before they send out the crown. So that can be adjusted, but there are other times where using the fit checker, occlude, TOB, or a high spot indicator helps a lot too. So let's see the diagrams. So the fit checker is placed, and then wherever there will be a show through, that's where it's hitting first. So that's the part that we need to adjust. Then the pressure spots should be uniform around the margin and not the internal surfaces. So there has to be a uniform pressure spot around the margin so that that's where the cement will replace the fit checker. Okay, so the steps for seating and removal. Seating and cementation of the crown. First, we are going to remove the provisional. Then we will clean the preparation. The proximal contacts are checked. Marginal fit is checked. Occlusion is checked. Aesthetics, color, and cementation. Okay, so I'm going to share a couple of videos. First one, let's see the crown impression. These videos are going to be available for you in the Google Drive as well. but I just want to go over what we discussed before. So let me start this. Second chord is intact. And I really like that they're using the Perio probe to help direct the chord as well. And this gently pressure is being used. And it's not piping, it's lateral pressure against the tooth. Actually from the tooth towards the tissue. Now they've dried the field. Okay. Right margin. The final impression. I'm just gonna jump straight into the next video because that's what we were just talking about, the crown cementation, and I really like this one. The temporary crowns are being taken out. And see this minimal pressure, it's almost like a flat instrument. Really slow. Traumatize the gingival tissues, and it's just a slight amount of pressure that helps take it out. And now they're cleaning the crown, sorry, the prep. Promise. Slow speed and peace. This is the trine. Go through the steps to check the contacts, margin, shape, and shade of the crown. So using the explorer to check the margins. Because it's an upper crown, just holding the crown in place so that we are sure that, if that's another reason why there can be an open margin if the crown is not been seated all the way, just because of the gravity. So that's why using the trine base in such situations is really useful, because now we can make sure that after removing the excess, that the margin is actually doing okay. It's easier to show it to the patient too. So if you can see, it was when it was tried in, it looked like there was a small gap between the two teeth, but now it wasn't visible. For some reason, they forgot to floss the contacts, but that's also important. Checking occlusion. This is the cementation for zircon. Etching. This is for this particular system, but every cement has their own set of instructions, so you can just follow whatever is being used in your lab. And this is for variolink, so just going through the steps. We're using the aesthetic one because it's an anterior crown. Very important to take out all the excess cement before you start curing for more than 30 seconds. It's really hard to remove it after it's completely set. You do a quick light cure. And then you want to take out all the excess cement at this step. Using a scaler is pretty effective. Go right under the gingival margins. And now they are flossing as well. A knotted floss helps take out all the excess cement from the interproximal, and then we do the light curing 30 seconds on each side. I think it's almost 2 minutes. And they still have some cement that they're taking out. Now they're going to start doing the occlusion check. This is really important, and they're doing it very well step by step. I really like this video for that reason. So they're doing the lateral occlusions, the patient is going from side to side, and every time they're using a different color articulating paper. When the blue one is being used, the patient is biting up and down. Now protrusion. So all the excursive movements are with a different color articulating paper. They're polishing the interproximal crown margin. And if there's any excess cement left, that will also be taken care of. Very gently with this. Polishing the crown margins. All right. So let's get back into the presentation and we come back to our favorite topic. Sorry.
Today we're going to have a great experience. This is Dale, and in fact, Dale's a dentist, and he has porcelain fusion metal crowns that were replaced. We just decided in 1958. It's 2015 now, so that's.
So we're going to talk about occlusion today, and there's a really good video that Dr. Jamani has done. So I'm going to just post the link so you guys can review it whenever you guys have time. Sorry about that. Okay. So what is centric relation? Centric relation is the relationship between the mandible and the base of the skull. The maxillomandibular relationship in which the condyles articulate with the thinnest avascular portion, non-innervated, of their respective discs. Sorry about that. My videos want to start talking before they need to. So centric relation, it's the relationship between the mandible and the base of the skull. So the maxillomandibular relationship in which the condyles, they will articulate with the thinnest avascular portion, which is non-innervative portion of their respective discs, with the complex anterior superior position against the shapes of the articular eminence. So this anterior superior is really, really important to remember. This position is independent of tooth contact. So in centric relation, the teeth are not occluding, versus in centric occlusion, it's the maximum intercuspation position. So it is restricted to purely rotary movement about the transversal horizontal axis. Centric relation, in again just repeating that the condyles in the anterior superior position along the articular eminence of the glenoid fossa, and with the articular disc interposed between the condyle and the eminence. What is centric occlusion? So centric occlusion is also known as maximum intercuspation position. It is the position where the maxillary and mandibular teeth come together. And this is what we are recording when we are asking the patient to bite. That's when we are taking the bite of the patient with the blue mousse. That's what we are recording, is the way the teeth come together when the patient is in maximum intercuspation. So I really liked another video. Sorry, these are coming all together, but I'm going to post the links. They're short videos, but they're really clear concepts. I think pictures and videos, they are worth 1,000 words.
Every one of us has clinical questions throughout our career. Every year, I receive thousands of questions from dentists from around the world. Each week, I briefly answer at least 2 of the questions, which range throughout all the areas of dentistry. My answers are based on research, dentist opinions worldwide, and my own personal observations. I invite you to send your own personal questions to me. Is there always a shift from centric relation, which you recognize as the most retrusive position in an unstrained situation, to maximum intercuspation, where you close together, so-called MIP, M-I-P? Used to be called centric occlusion. For you old guys, that's what you learned. Now it has to be called MIP, just to keep you confused. Yes, there's almost always a shift. Watch me. I'm going to take my jaw back to centric relation and tap, and then bite. And what just happened? It went forward a full 1.5 millimeters, which is about average. It should go straight forward, not deviate left or right. If it goes left or right, that's one of the potential pathologic conditions relative to that shift. There's something I always test. CR, centric relation, to MIP, MIP, is about 1.5 millimeters straight forward in well over 90% of the population, and should be considered when you're doing restorative dentistry. Let's say I have a bridge to be done on my left side. If I did, and if I had the shift I just showed you, and if I was comfortable in every way, I would retain that shift. No reason to take it out.
On the other hand, if I'm doing a full mouth rehabilitation, there's only one relocatable position, which is centrigulation, and I would eliminate the shift. Take a look at our occlusion videos, which go through.
All right. So let's get back to the presentation. Okay. So VDO or vertical dimension of occlusion or occlusal vertical dimension. It's the vertical level at which centric occlusion occurs and establishes the anterior face height. So basically when your teeth are close together, and that's where the vertical dimension of occlusion occurs. You can take a point on the nose and the chin and have the patient bite and then measure it. It's like, yeah. And then, of course, you use like a scale, and we used to use a thread, and then we used to measure that on the ruler when we're working on edentulous patients. And then vertical dimension at rest. So this is the position in which the mandible is in centric relation and the teeth are not occluding. So I really like this picture, so I added them to the slides. The gap between the VDO and VDR is known as freeway space, and average freeway space is 3 millimeters. This is something that I would want to remember if I was going to study for an exam. Okay, so what are the occlusion goals? We have So these are the factors that help us determine that the occlusion is normal. So first thing is that the centric occlusion is stable. Every time the patient bites, his teeth close into the same relationship, that it makes it repeatable. When we check with an articulating paper, we get simultaneous even contact on the posterior teeth enclosure and light contact on the anterior teeth. The COCR relationship should be harmonious, and there should be no defective slides when opening or closing the mouth. We just saw that in the video too. The contact should be on the functional cusps and not on the balancing or non-working contact cusps. And then the canine guided relationship is a mutually protected occlusion where the vertical and horizontal overlap of the canine teeth causes disengagement of the posterior teeth in the lateral movement of the mandible. So I'll show you a video on it too, but like just a quick, let me see if you guys can see this properly. Okay, so you can see how, when I'm doing the excursive movements, the posterior teeth are not touching. So that is what happens in a canine guided occlusion. Basically, there is, we'll talk more about it in the next. Disocclude the posteriors in protrusion. Okay. And the other thing is the group function occlusion, and that happens in the working side. There's distribution of occlusal load, and it prevents the teeth of the non-working side being subjective to destructive, obliquely directed forces. And the anterior teeth disocclude the posterior in protrusion. So I know these are coming really, really close, but I like to show this video about canine guidance. These are really hard concepts to understand, so I like the fact that the videos are very
where your canines ensure that the back teeth don't contact when the jaw is slid to the side. This is important because the back teeth are good at taking longitudinal forces, but they are not built to take off center forces. You can check if you have good canine guidance by moving your jaw to the side while maintaining contact between your canines. Here you see an example of someone with good canine guidance. Throughout this motion, you should feel no contact between your back teeth, whether you move to the left or the right. If you do feel a contact, called an interference, chances are that you're beginning to experience problems with the contacting teeth and need some work done to prevent increasing problems in the future. Finally, note that total canine guidance requires 3 features to be working in harmony. Near-side guidance, that is the side you are moving towards, mostly depends on the first 2 of these features. First, the position and slope of the inside of your upper canine. Second, the position and length of your lower canine. Far-side guidance mostly depends on the third of these features, namely the fact that the condyle, that is the upper part of the jawbone, is being forced down as it navigates the downward slope of the far side jaw socket, something you can observe if you watch this animation closely. These 3 factors combine to provide canine guidance.
So short videos, but they explain a lot. So, okay. So let's start talking about the functional cusps. And I have some the model again to help us just determine. So what are the functional working cusps? They are the cusps that are in function when the teeth is in maximum intercuspation, and they do the brunt of the work while we are eating or occluding. So that's why they are called working cusps. So which are the working cusps? Very important again for an exam is the maxillary lingual cusps. So I have just colored them out so that it's easier to see. But that's not that visible. So the maxillary lingual cusps over here, and then the mandibular buccal cusps. Sorry, it's not as useful as I thought it would be, but still, let's see if you can see that, right? Okay, and then what would be the non-functional cusps? So the opposite, right? So the maxillary buccal cusps and the mandibular lingual cusps. So yeah, these can be like good trick questions in the exam too for you. Classification of occlusions. What's class 1, class 2, and class 3? I'll go over and review these. So the mesiobuccal cusp of the maxillary first molar is aligned with the buccal groove of the mandibular molar.
These definitions and demonstrate them very well, and how they relate to your normal day-to-day.
All right. Class 1 occlusion, and how does it come in relationship with the while we are cementing crown? So let's talk about that now. So the horizontal overlap or the overjet is supposed to be 2 millimeters, and the vertical is overlap is 2 millimeters. So what helps with the vertical overlap is that it helps eliminate the tooth contact in excursions. So because there's that height, so when we are moving the tooth in excursive movements, because of that height, we get the disocclusion that we want. Increased horizontal overlap. So if there is an increased horizontal overlap, then the anterior disclusion may not occur because the teeth have to travel more, and and over time it also causes some recession on the anterior teeth, and that also makes it a little bit more harder for the anterior disocclusion to occur. And in this case, the posterior group function exists. So we had seen what the group function was. In the working side, there is distribution of occlusal load, and that prevents the teeth on the non-working side from being subjected to the destructive oblique forces, which was also seen in that video that we just saw about canine guidance. So class 3 occlusion. So what happens in class 3 occlusion? Okay. So there's another video, I'll post that will show the 3 occlusion positions really well. And then let's see, 42. Okay, So I'll just go over the class 2 occlusion again. So in this, just imagine that the upper jaw, it moves forward by half a cusp. So then the mesiobuccal cusp of the upper first molar, and this is, so you kind of try to move this forward so you can see. No, this is really hard. But basically just remember that the mesiobuccal cusp of the upper first molar is mesial to the buccal groove of the mandibular first molar. So if you were to see which to come in contact, is the maxillary. This is where the red line is. It basically is the class 1, but I tried to draw a blue line here so I could show you that these are the two areas that would come in contact: the maxillary buccal cusp with the mandibular buccal cusp. So that happens when there's class 2. And yeah. In class 1, the vertical overlap is more, so the posterior teeth disocclude during excursions. But in this case, the overjet is more, so anterior teeth might not disocclude the posterior teeth, and the group function occurs. And the group function is present when contacts are maintained between several teeth on the working side during lateral excursion of the mandible. Okay, so class 3 occlusion. So there is a posterior crossbite in class 3 occlusion because the lower jaw is forward, and that affects the functional cusps. So basically, they would reverse, right? So the contact is on the non-functional cusps, and the anterior crossbite relationship also affects the disclusion. So in the class 3, lower jaw is protruding forwards, and the posterior crossbite relationship affects the functional cusps. The canine guidance will be unlikely, and the posterior group function is indicated. So if it's class 1, typically canine guidance is present, and class 2 and class 3, it's most likely the posterior group function. What does the group function help with? It evenly distributes the contact, so then there's not that loosening of the teeth that can occur because of the protrusive movements. So mutually protected occlusion. What is mutually protected occlusion? It is the occlusion that exists when canine guidance is present. When a patient bites on the articulating paper, we see that the contact is heavier on the posterior teeth, it's lighter on the anterior teeth, and there is canine guidance on anterior teeth in excursive movements, and posterior teeth disocclude in excursive movements. So this is good to remember. Again, for an exam, I can see that it's possible that they will just give a couple of points and say which of these are not true, or all of the above kind of a question. So occlusion goals: single unit restoration should be completed in harmony with the patient's existing occlusal scheme. Occlusal interference should be eliminated as a part of the seating process. So the whole reason that we were discussing occlusion today again is that we don't want any occlusal interferences, and of course the bite should feel normal to the patient. So what are the occlusal interferences that are present? So one is centric occlusal interference, that is when the patient is biting in centric occlusion. Then there's working occlusion, that is laterotrusion. So this is going to be the working occlusal interference because it's going towards the lateral. So towards the center is the medial, and towards the side is the lateral. So if the working is moving towards the side, that means it's laterotrusion. And you can see the same time the balancing is, or the non-working is going towards the medial, right? So this is going to this side, so this one will go to the center, and basically lateral is off center. So that is the working and non-working interference and protrusive. So basically what it's explaining is that when we are checking the bite, we tell the patient to bite up and down, we tell them to bite side to side and forward and backward to record the interferences. So balancing occlusal interferences, balancing buccal inclines. So what are the interferences that happen? So the balancing interferences are, so when we are moving this way, what will be interfering in, what will come in the way and what needs to be adjusted when we see the markings on the articulating paper. So if we see on the buccal inclines, sorry, buccal inclines of the maxillary lingual cusp. I don't know if you guys can see, I've marked that in red. And then the other on the mandibular side, it's the lingual incline of the mandibular buccal cusps, right? So if you see markings on those areas, you want to make sure that they are adjusted. And then on the working side, it's the opposite. So I don't know if you can see the markings again. So yeah, I can see now. So the lingual inclines of the maxillary buccal cusps and the buccal inclines of the mandibular cusps. The buccal inclines of the mandibular cusps are the working interferences. And what are the protrusive interferences? So on the, it will be the distal inclines of the mandibular teeth, the distal inclines of the mandibular teeth, and the mesial inclines of the mandibular, distal inclines of the maxillary teeth and mesial inclines of the mandibular teeth. So I'm trying to create a protrusive movement. I'm not sure if it'll work, but you can see that where it's touching, it's going to be the distal inclines of the maxillary teeth and the mesial inclines of the mandibular teeth. Okay. So this diagram here shows the same thing that we just saw on the model, balancing buccal inclines of the maxillary lingual cusps against the lingual inclines of the mandibular buccal cusps. And working is lingual inclines of the maxillary buccal cusps and the buccal inclines of the mandibular cusp. Sorry, there's something I have to edit out in these. And the same thing, protrusive distal inclines of the maxillary teeth, mesial inclines of the mandibular teeth. So again, potential question for the boards. Occlusion evaluation. Check the patient's occlusion before trying to verify repeatable centric occlusion closure so that you can identify the points of contacts as a reference. So you could just see how the occlusion is on the existing teeth before the crown is tried in. So you know where the teeth are touching in their regular occlusion. So again, this is the excursive pattern that happens during canine guidance. You can see that there's a gap. And whereas in the group function, they're touching and they're trying to distribute the forces to prevent periodontal problems and mobility in the future. Occlusion checks. So how do we know that the occlusion, which is now, the importance, how important it is to make sure the occlusion is good. Otherwise, there's no way that the crown can be okay in the long term. I've seen patients who have normal teeth, occlusion is not right, and they start having periodontitis, and a tooth that was completely fine now needs a root canal, or it can cause a long-term damage if the bite is not corrected right away. So one thing I always tell my patients, if I'm doing a filling or crown, if the bite doesn't feel right, once you go home and the numbness is worn out, I want you to see you like within a week. I don't want the periodontal ligament to get too much of trauma because the bite is not correct. So very important to make sure that it's feels right. So the way the adjacent teeth are touching, that should feel normal. So typically if the patient is numb on one side, I usually try to ask the patient, how does the side that is not numb feel? So, it's hard to check if your bite is feeling okay, like after you've done all the adjustments to confirm with the patient. So if they say I'm doing something on the right and the left bite feels normal, there's only one way that that's possible, is that the other side is normal too. So patient awareness, again, we just talked about it. Some people know right away, this area it's touching and the other people can't tell. So articulating paper and then checking the bite on the opposite side is a good way for them to figure it out. And sometimes just holding the cheek helps to also just kind of make you feel that does it feel okay or not. The mylar holds on the adjacent teeth. So there's a picture that will make that we can explain that with. Again, occlusal indicator wax, articulating paper or ribbon or tape, and direct marks on the airbrush surface. All of these ways, and surface coating, TOB or occlude products are the way that we can check the occlusion. So these are the mylar tests for centric stops. So basically, when the crown is placed and then you put a mylar strip or a thin strip in between teeth in front of the crown and in back of the crown, behind the crown. So if you place the paper and there's resistance in it coming out, that means that the crown is seated or the occlusion is fine because it's tight, right? Unless it was loose from before. And then the same thing at the back. So this is a really good indicator of how the occlusion is after the crown is seated. Then these are other ways. So you have a TOB high spot indicator. It's useful in metal crowns where it's harder to figure out where the articulating paper has the marking. Sometimes they don't mark so well. Occlude spray, so that's to check on the internal surface to make sure that the crown is seating evenly. Sometimes that could also affect the occlusion, because if it's not seating all the way, of course the margin is going to be an issue, but then also the occlusion will be high, right? So what do we use for occlusal adjustment? We have a metallic tapered finishing carbide burr, and it's a Brasseler H28, 1K or 012. And then after that, you have the brownie and the greeny points to polish. You can also use a ceramic for metallic rounds. It's the carbide burr. For ceramic rounds, we want to use a tapered medium grit diamond stone and polishing points, porcelain polishing points. And again, the number of the burr is given. I also sometimes use a fine football diamond. It does a pretty good job of checking the adjusting the occlusion. And very important to maintain the cusps and ridges of the contours. So you don't want to flatten the crown. These days such beautiful crowns are made in the lab with all the anatomy the way it's supposed to be. So try to maintain that as much as possible. And if there's so much of adjustment needed that the anatomy is kind of going away, there's something wrong with the way things are. So excursive adjustment, articulating film to mark the excursive contacts. So you want to use a different color for the centric contacts. The video was really well done. So you want to adjust the undesired excursive marks and leave the centric spots intact. The mylar check is used for release in excursions. And of course the patient feedback, they are the ones who are have the crown, and few microns can make a lot of difference, which is hard to see in the paper. So that's like the most important thing, that how does it feel. And using the opposite side is a really good way to make sure that if they can't tell, but typically with crown they are not numb, so they have a pretty good judgment of how their bite feels. Okay, so these are all the cements that are available for us to cement the crown. Zinc phosphate, polycarboxylate, glass ionomer, modified glass ionomer. I don't think we use that often. Actually, glass ionomer is a good way. So if if there's a crown placement, and let's say the patient had got a root canal done, the symptoms are still there, but sometimes the symptoms take a little while to go away if there's like too much of periodontal, periodontitis. So if you use a glass ionomer, like a permanent cement, but it gives you a little bit of leeway. Say suppose the crown needs to be removed for some reason, then um, glass ionomer is something that I saw a dentist use in the past. Resin auto cure, and resin dual cure, and resin light cure. So we saw the resin light cure in the video. Okay, so cementation process. First, you have to clean the preparation, then you condition it, you clean the restoration, condition the restoration, isolate the preparation, and you mix and apply the cement. And once the cement is placed, you want to not use a lot of time and seat the restoration right away. Make sure that it's seating correctly. Apply seating pressure. Typically, put a cotton roll, ask the patient to bite for a couple minutes. While seating, after the patient is biting, I typically take a gauze and try to clean off all the cement as much as possible on the buccal side by retracting the lip, but not touching, making sure, I mean, it's more important that the restoration is placed and seated, and then you can always take out the excess later. If there's easy access to just retract the lip and clean it up, then do it. Otherwise, just leave it for later. Then, of course, you want to recheck the occlusion, reapply the pressure, remove the excess cement around the margins, and then floss with a knotted floss to remove the cement around the contacts. Incomplete cementation seating. So if this happens, it's a little bit of I don't think that's happened to me, maybe once, but I don't even remember if that was in dental school, whether that was for me or it was one of my friends that it happened to. Delay after mixing. So that's why I was saying that the moment you have the cement, and again, the amount of cement that you use is really important. I try not to make it less. Of course, if it's a little bit more, it's totally fine. It should not be less. And but it shouldn't be like filling up. So typically like half or a little bit less than half of the amount, like basically the crown is like a trough, right? So you don't need a little bit more than, if you were to just line the crown with the cement, and just do a little bit more than that. If there's not enough excess, then it's very easy to clean it out, but it should not be less. So definitely err on the side of more than less. If you have not seated, does not use adequate pressure, so then the crown will not seat all the way. And sometimes, so that's another thing that's really important. Before you put the cement in, you need to know what is going to be your path of placement, especially anterior teeth. So if you put it and it's not in the right spot, you have to make sure where exactly it's going to touch, and where your margins are going to touch. You have to look for a landmark. So it's really important for me to make sure that the crown is seating right. And this is especially in case where they're like two adjacent crowns. So you have to be more careful in those kind of situations. Cement removal. So yes, so this part is really, really important. And how do you start removing the cement? So like I mentioned, the first thing that I try to do, I don't do it if I feel that it's going to affect the way the crown is seating, is taking the gauze and try to clean it out. But after that, the next step is that I wait for a couple of minutes for the cement to set, but not completely. So I start with my explorer, and again, the specks of cement that are easily taken out, just going over the surface parallel to the margin and away from the gingiva. You start taking out the excess. Then the next step I go to is the scaler, and that does a pretty good job of taking out most of the excess cement. Of course, starting on the buccal, then going to the mesial distal, and then getting to the lingual. And sometimes that's where a lot of cement is at. So it's good to just quickly take a 360-degree look and see where there's a lot of cement and take that out first. You don't want to do one side and then the other sides have been become too too hard already. So just being mindful, and like once you do it a couple of times, you really get the hang of it. I think for me, I feel crown cementation is one of the most important, but it's not that technique centered. It's a pretty straightforward procedure. Then the positive finger resting is just that you make sure that you have support. Otherwise, say you don't have the hand support, like the finger rest, then you can dislodge the crown because it's not all the way set. Force directed parallel to the margins and away from the gingiva, and the knotted floss on the interproximals. So you have to rinse and evacuate. Sorry. So now I'm just going to quickly review about the lab exercises that we are going to do on the day that we're going to meet for the practicals. Going to make sure that the typodonts are equilibrated. Going to practice polishing, and then we're going to be seating these 3 crowns. Number 3 full gold, 19 PFM, and number 8 ceramic restoration. So seating the number 3 full gold crown. What are going to be the steps? You will adjust the proximal contacts, verify seating, evaluate occlusion. Centric occlusion needs to be adjusted, excursive adjustment, the final polishing, and the cementation. So these are the pictures that, like the proximal contacts, and then the articulating paper to find out where it's tight, then verify the seating. And then the occlusal adjustment is done with, you can see the mylar strips on front and on the anterior and posterior to the crown. And then the occlusion is adjusted with articulating paper. So if you see these blue spots over here, when I notice that my adjacent teeth are in contact, that gives me a good sense that, okay, if my adjacent teeth are touching, the crown is pretty much in occlusion. That's why the adjacent teeth are back to their original occlusion. So that's another thing, that when you before trying in the crown, if you know that this is the way the teeth are touching, then it really confirms it really well that, okay, if the occlusion markings have not changed, then my crown is seating right. So adjust the proximal contacts, verify seating, evaluate occlusion, centric occlusion adjustment, excursive adjustment, final polishing, and cementation. It's just a repeat of the previous slide. And now seating of the PFM, which is so here we have the porcelain polishing burrs and then the coarse or medium coarse diamond burr for adjusting the occlusion. And then again, using the 2 different articulating papers, the red ones are the the centric stops, and the blue ones are the excursive movements. So you want to adjust where the red and the blue coincide. Seating the number 8 ceramic crown, anterior crown. So yes, and this is back to the first slide. So we complete the presentation over here. Thank you so much for giving me this opportunity. I really enjoyed the process, and even though it was tough for me to really take out the time for this, I've been doing these recordings pretty much between 4 and 7 or 8 a.m. in the morning, just depending on the time my husband's meeting starts. So I have to be done before that, and my son is sleeping. So but it was a really good learning experience for me to record on Zoom, and please feel free to reach out with any questions. I look forward to seeing you guys on the day that we're going to be doing the lab exercises. Hope you guys are staying safe, and happy Halloween, and we'll see you guys in November then. Take care. Bye.